Welcome to the Using Data to Drive Community Quality Improvement Efforts conference call. My name is John, and I'll be your operator for today's call. At this time, all participants are in listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you do have a question, press star then 1 on your touch-tone phone. And now I'll turn the call over to Ross Gatsky.
Thank you, John, and good afternoon, everyone. My name is Ross Gatsky, and I'd like to welcome you to today's webinar, Using Data to Drive Community Quality Improvement Efforts, presented by Lake Superior Quality Innovation Network, or LSQIN. The LSQIN is comprised of 3 organizations, MPRO in Michigan, Stratus Health in Minnesota, and Medistar in Wisconsin, to support the Centers for Medicare and Medicaid Services Priorities for Healthcare Quality Improvement. We know that you and your organizations are working hard to improve healthcare quality, reduce readmissions, support the culture of safety, and improve outcomes. We hope that today's topics related to data and analysis will support these efforts. Our speakers today are Rahul Paul and myself, Ross Gatsky. Rahul is a data analyst who has been with Medistar since 2016 and really has a lot of experience working with the data analysis and methodology design with multiple data sets, but especially with the Medicare claims data. I am a project specialist that works on a variety of tasks, including the coordination of care task, which is the most applicable to today's topic, through my experiences working with community coalitions on their quality improvement efforts. This session is being recorded and should be available in about 2 weeks on the Lake Superior Quinn YouTube page. The PowerPoint presentation is a WebEx handout located on the registration page under Event Materials. All lines will be muted during the webinar. However, we will have time for questions and answers after the presentation, so please be fully present and engaged and make note of any questions that you have as you listen. And also feel free to share your thoughts or comments in the chat box. Because Medistar is providing continuing education credits for this presentation, we need to inform you that no commercial support has been received for this learning activity. The speakers and planners have reported no conflicts of interest. For continuing education credits or a certificate of attendance, you must attend the entire session and complete an online evaluation. And we encourage everyone to complete the evaluation to provide feedback on the session. And then once the event is ended today and you close out of the webinar page, you'll be automatically routed to that continuing education credit survey. So what we want to accomplish today through today's presentation is we want to illustrate the potential of data and how it can be used within the quality improvement, or QI for short. And we will support the effectiveness of data analysis within QI through an in-depth community example. And I do want to mention that while we provide a community example for this particular webinar, the themes that we stress today can be applicable to facility or organization-specific quality improvement projects as well. So a hospital or a nursing home, for instance, could use what they learned today for their own QI efforts. It doesn't necessarily have to apply to just a community QI project. And finally, we will provide some takeaways of how data can be used to identify gaps in patient care, support implementation, and track effectiveness and progress of interventions. So today's topics include the role of data in QI, and we really want to introduce this to those who may not be as familiar with this topic, and while reinforcing the ideas of the importance of data in QI for those attendees who may have more experience. We will also discuss the different types of data, the collection of data and how it's analyzed, and data monitoring. And finally, again, we'll discuss the role of data within the community level example. And with that, I will pass the baton to Rahul, who will present the first piece of today's presentation, which discusses the many topics within the role of data in quality improvement.
Thank you, Ross. I always like starting conversation about data in quality improvement with this code. I don't know who who said this, but it's a great representation of the importance of data in any quality improvement effort. We will start by talking about the role of data in quality improvement. Most of us are familiar with the model for improvement put forth by the Institute of Healthcare Improvement. And essentially the model says that, we want to start by setting our aims. Once we have those, setting our aims for the quality improvement project, once we have those, we want to establish measures and to be able to measure our progress, and then prioritize the changes or select the changes that we think will make an impact and will result in improvement. Once we have those set, we go into a PDSA cycle, which again most of us are familiar with. And the important part here are the arrows that essentially are a cycle which says that we go through multiple PDSA cycles to really understand the impact of our improvement effort and to fine tune it. This particular representation is more or less the IHI improvement model, but I find this a little bit more intuitive, so I thought I should share it with everyone. Where it represents the start of a project, there's an initiation phase where you're essentially trying to figure out what area you want to settle your improvement efforts on. How do you prioritize between the different areas that you've identified? Then you go through, once you have the area that you want to prioritize and make an improvement effort in, you go through these multiple PDSA cycles. And I think the key in this diagram is the multiple PDSA cycles in the intervention phase as opposed to having one PDSA cycle. So I think this particular model just makes it a little bit more obvious that we do go through multiple PDSA cycles. Once we've done that, we can measure the impact of the overall project and then figure out how to sustain the improvement that we've gained through it. And around that circle, we can see the different things that support our QI efforts. And the one that we choose to focus on is data in this particular presentation. So data essentially is an important part of every step in our improvement cycle or model that we've seen in the previous two slides. It helps us identify and tackle the right problem by essentially helping us identify the gaps and needs that we may have in our particular setting or community. It also helps us prioritize those problems by gauging the impact of those on our patient population or on the outcome that we want to improve. One thing that doesn't get mentioned as often is we can use data to help get buy-in from our management, which essentially is one of the most important parts of being able to execute a successful QI project is management support. It also helps us implement the right strategies and solutions. Usually when we're going through the intervention phase, we, as mentioned before, as the model shows us, we go through multiple PDSA cycles, and we can fine-tune based on the data that we get and the analysis of it. We can fine-tune our strategies or choose a strategy that is more effective at getting to that improvement that we're looking for. And finally, we can demonstrate the required outcome and then monitor for continued improvement within our community. And data has an important role to play in each one of those areas. One of the most significant challenges that one faces is choosing the right measures for impact. It is it is very important in essentially the success of the QI effort depends on choosing the right measurement. We want to make sure that we are measuring what we want to improve. And this could be anything from change in a process or in a clinical practice to actual improvement in clinical impact. So whatever we think, based on the aims that we have selected for our project, is our outcome, we need to make sure that we're measuring those to be able to establish whether we are making any progress or not. Once we've established the right measures, we need to collect and then analyze this data, and then the key here is we'll be doing this multiple times throughout the PDSA cycles. And then the strategies that you use to collect and analyze that data depends upon the measures that you've chosen among other things. And we'll talk about that because it depends upon the type of data and what your outcomes are going forward. Okay, so what we will do is we will scratch the surface of a huge knowledge area that exists, and we'll be talking about the types of data collection methodologies, the analysis and monitoring of it. We're going to stick to the basics here in the interest of time, but there's a lot of information available on both the IHI website and on CDC and CMS websites that help us with these efforts. So there are two major categories of data, and there are many different schemes of categorization, but this is the one that is used fairly commonly, and it kind of drives how you collect the data and how you analyze it as well. So the first major category is qualitative data, and really the defining feature of qualitative data is that it's descriptive in nature. It's usually interviews or texts or speech, even videos, audios kind of form, or all of those could be forms of qualitative data. Quantitative data, on the other hand, is more numerical in nature, and we could have sums of things. We could have counts, or we're counting different things. We have ratios, rates, and percentages. Those also qualify as numerical or quantitative data. Usually ratios, rates, and percentages are great for comparisons, and we'll talk about that in a little bit. There's also categorical data. We essentially categorize certain, people in certain groups. There are two subcategories to that as well. There's ordered, where essentially the order of the category matters. Ranks are a great example. So first rank is usually better than rank 2, and so on and so forth. So ranks are a great example of ordered categories. And then there's unordered categories that we can divide we can create groups from, which could be anything from gender, race, and other demographics, where there's no particular order to one category or the other. Qualitative data is great to collect when you're trying to understand a problem or a process more deeply. It's great when you don't have any information about the area where you want to do a quality improvement effort, and you really want to understand what's going on. Then qualitative data is what you would collect, because it lets you answer the question of how and why. So how does something happen, and then why it happens the way it does. The caveat there is you can't collect a lot of data because it's a very intensive process. There's a lot of notes and videos and audio that you have to go through. We'll talk about the different collection methods in a little bit. Quantitative data is more objective in nature because it's numbers. Numbers are usually a universal language. And then the conclusions that we can draw from those are a little bit more robust, and you can usually you're usually a little bit more confident in those conclusions, especially when you're trying to generalize to a larger population. So qualitative data, when you're trying to understand a particular process and how it works and why certain things work and others don't. And quantitative data is more for being more confident in conclusions and more robust in your outcomes. So moving on to some data collection methods, and this is by no means an exhaustive list of the ways you can collect data, but brainstorming is one, root cause analysis, affinity diagrams. We use that, I know, in our line of work pretty often to understand why a certain process works or why it doesn't work, or if there's a problem, then what could be the reason for that problem. And that kind of falls into the qualitative data category. Process mapping is another great way to collect that kind of data. Focus groups, key informant interviews are a great way to understand how things are happening in the field or on the floor, and again, that qualifies as qualitative data. Audits, surveys, and questionnaires are a great way to get data, which is mostly quantitative data in this case. EHRs and administrative claims data. Now, these are also known as secondary data because these EHR data and claims data in particular, we collect for other purposes which are not connected to our particular intervention that we're trying to do, but we can use that data to gauge the outcome of our improvement effort. So the ones at the top, brainstorming, process mapping, focus groups, and key informant interviews, are both ways to collect data and in some cases even do some sort of analysis. So when you're doing a root cause analysis, it kind of is a way to collect what the process is, to understand what the process is, but also to see, to analyze where the fault in the particular process is. So those can be both a way to collect and analyze data, especially in qualitative methodologies. All right, so in the data analysis methods, we're going to focus a little bit more on the quantitative side of it. We briefly talked about the qualitative analysis using brainstorming, etc., but we're going to focus on our quantitative side of the analysis methods. And really the first and the most common thing to do once you have the data, once you've collected your data, is to do a sort of descriptive analysis of that data. What you're trying to do is you're trying to summarize that data and understand what it means or what is it trying to tell you. Two great ways to understand what your data looks like and to create a summary of that is to use measures of central tendency and measures of variance. The mean, median, and mode are usually called the measures of central tendency, and we usually mean is just you add up the values and you divide it by the number of values in there, and that kind of gives you a mean or an average. As it's called, the median is you sort all of the data and you pick the value that lies in the middle, and that's a great way to see what your data looks like. Mode is the most commonly occurring data value, which is the most frequent value that you see in your data. That's another great way to measure central tendency. And the example that I like to give when talking about central tendency and how they're useful is about height. So if you want to see what if you have a data set with the height of all of our patients, and we want to, see how do we summarize that information, a great way to do that is to look at average height, and that will kind of give you an idea of what height looks like in your population. Measures of variance are just as important as measures of tendency, and maybe even more so in some cases. the most basic way of looking at variation in your data, how much change there is from one person to the other, from one data point to the other, is range, which essentially is you take the maximum value and you subtract the minimum from it, and that becomes your range. The inner quartile range is a bit of a variation on the range. Instead of taking the absolute maximum and the minimum in all of your data sets, you go at the 75% mark and the 25% mark, and you see how far apart those are. And one reason why you may want to pick inner quartile range over a normal range is if you have extreme outliers, because that can really mess with your range and hopefully not make as much an impact on your inner quartile range. And that's why you want to choose one over the other. Standard deviation is the most commonly used and the standard way to calculate variance in your data. It essentially is a measure of how far away each data point is from your mean. So it kind of sees how far away you are from your central tendency and kind of summarizes that, and that's what standard deviation is, and it is by far the most commonly used variation measure. So getting a gauge of those two things, your central tendency, whether it's your mean or median or mode, and then variance, which usually is standard deviation more often than not, gives you a great idea of what your data looks like, what it means. A great way to quickly do this, instead of looking at numbers, and sometimes, as they say, pictures worth 1,000 words, is to create charts. There's some charts, especially the histogram and the box plots, that are a great way to look at both the central tendency and the variation. So one chart essentially gives you a good summary of what your data looks like. Scatterplots are great when you want to explore a relationship between between two or more measures or variables. Usually scatterplot, you want to restrict yourself to two variables. It essentially tells you if you change one variable, does it have an impact on the other? And that's kind of what we're looking for when we're doing an intervention. We try to change this one thing so that we have an impact on the outcome, which is this other variable. Again, a scatter plot is a great way to see which variable, when we change it, has an impact on our outcome. Pie charts are a great way to look at proportion of things, but bar charts do an equally good job of that. And then Pareto charts are essentially sorted bar charts. So if you take a bar chart and you sort it by a particular value where, usually the largest is first and then the smallest one, and then it goes in order to the smallest one, you come up with a Pareto chart, and sometimes it has a cumulative line on top of it. But really, the reason why you would want to use bar charts and Pareto charts is to identify and prioritize areas. So you can look at how many readmissions you have in a particular diagnosis, and if you have a bar chart, you can look at which particular diagnosis has the maximum number of readmissions and choose to focus on that particular area. Finally, line charts are a great way to look at trends and shifts, and those are both a great way to choose which particular area you want to pick to do your quality improvement on, and to look at the impact of your quality improvement effort. They also let you know how you do it. Usually the line charts are over time, and where we draw it, we want to see how things change over time, and that's usually where we use line charts. So before we move on to the main data analysis methods, I wanted to talk a little bit more about variation or variance in the concept of common cause variation, special cause variation. So whenever we try to measure something, there's always going to be some sort of measurement error, and there's going to be some noise that we capture in our measurements. That noise is usually known as common cause variation. It's usually a natural pattern, and it happens because of chance or random error. And there's nothing much we can do about it, so we just simply accept it being there. but we know that chance or common error has certain bounds and it doesn't go beyond that, and so we can figure out whether a particular change is because of chance or is it because of some sort of special cause or systematic error, or whether it's unnatural. And that's really what we're looking for. We are looking for this special cause variation where we can assign a cause to it, and then we can make changes there to make our process better. And that's where variation's importance comes in. One way to visualize this common cause and special cause on a chart is to use our control or Shewhart charts, as they're known. Usually what we do is we plot the mean, and then we look at the data points around the mean. We usually even have an upper control and a lower control limit, which is essentially a multiple of the standard deviation for the variation that we're talking about. So what we do is we say we accept a little bit of variation between the upper control and the lower control limit, but any variation beyond those is special cause, and we want to investigate that. So here's an example or chart that has a sample control chart that has the upper control limit, lower control limit, and the mean, and we can see the data points around the mean, how they vary. Now, the chart on the left kind of shows a process that is more or less in control. It's within the main upper control limits and lower control limits. And there are many different ways to decide what these control limits are, and it really depends upon how stable you want the process or how tightly you want to control it. In this case, let's assume that it's good as long as it's below the upper control limit and above the lower control limit, and it seems like the process does fine. The chart on the right, though, if you notice, there's this one data point that actually crosses that upper control limit, and we kind of want to investigate why that is happening. Another thing that we want to watch for is how often it crosses the middle line, and if it's common cause variation or chance error, then it should more or less be regular enough crossing that line, so sometimes above the mean, sometimes below the mean. But if it's consistently in one side of it, so if it's consistently above the mean or consistently below the mean, then we know, again, there is some sort of special cause variation. So this chart helps us tease out those and then maybe focus our improvement efforts on. So once we're done with, looking at central tendencies and shape of our data and variation of our data, we can kind of look at impact analysis once we have our quality improvement effort going, our intervention going, and we've been through, at least one PDSA cycle. Now, there are some non-statistical techniques that doesn't really require you to do any statistical tests, and these usually include looking at if there's a trend or not, because oftentimes just having a trend means a successful quality improvement effort. And usually a trend is described by 5 or more data points in one direction, so either going up or going down, whichever particular direction they are moving in. So you want at least 5 or more data points to definitely say there is a trend there. It's not because of chance. And here's an example of that. So those 2 areas that are circled demonstrate a trend, and one can try and investigate why those trends existed or what was the cause for it. The other thing that you may want to look at is a shift, which is essentially what's happened now is your whole process has shifted in value. Your data points move on the, so it's instead of a gradual increase or gradual decrease, there's a sudden shift in your data. And usually 4 or more data points above or below the median or mean indicates a shift. And here's an example of that shift. So we notice how those 4 or 5 points are above the mean. They indicate a particular shift, and then later on there's more points that are below the mean consistently one after the other, and that again indicates a shift. Again, those help us identify areas for improvement or even figure out the impact of our intervention. So maybe there was an intervention just before that shift happened, and then we can see the impact of that intervention in that shift in the graph. So these are two ways that you can gauge the impact without really using statistics in any way. Before we talk about some of the basic statistical techniques, I just wanted to bring up this bell curve that's known as or the normal distribution or the Gaussian distribution. Many names for this particular distribution, but the reason it's called the normal distribution is because a lot of things that we see in normal life follow this particular sort of shape or distribution. And all it means is there are a lot of data points in the middle around the mean. There are very few extreme data points. And this kind of applies to a lot of things that, again, like I said, we see normally in our life. When you think about height, a lot of people are usually around the average height. There are very few who are very tall and very few who are very short. So that's how a Gaussian or normal distribution works. And that center right there, the peak of the distribution usually is at either the mean, usually the average or the mean of your data. And if it's perfectly normal, then your mean, median, and mode are exactly the same place. And that's what this particular one demonstrates. Sometimes you can be skewed. You can have a distribution that's slightly skewed, and in that case, your mean, median, and mode don't fall on the same point. But the mean is what you want to look for in this case. So what property that we use all the time of the normal distribution and forms the basis of a lot of statistical techniques that we use is that 68.2% of all data values or data points fall within one standard deviation from the mean. So this box that you see right there. So you can say in this particular case, all 68.2% of all patients had a waiting time of between 50 and 100 days, with the mean being 75 days. So that's usually how a normal distribution behaves. 95.5% of all data points or participants usually fall within two standard deviations, which is plus and minus from the mean. And then finally, 99.7% of all data points usually should fall within three standard deviations of the mean. And this is a property that we use to do our statistical tests, to do our confidence intervals. When we say we're 95% confident, again, what we're doing is we're attaching those standard deviations with subtracting and adding that standard deviation to come up with a range, and we're sure that 95% of the time it will fall within that range. And this is how we come up with it, because of the property of our normal curve. So really the whole aim of doing a statistical test, and in even some cases confidence interval, is to see, is the change that we're noticing because of chance, or is it because of the intervention that we're doing? And that's really what we're trying to figure out when we're doing tests for statistical significance. It also helps us generalize data from a small population to a larger population. So confidence intervals are, again, as I mentioned, essentially we provide a range of values that the outcome can fall in. Now, usually when we're measuring data, we can't measure it for every patient out there or every participant that's out there. So what we do is we pick a small sample, and then we do the test or we do the measurement and intervention on that small sample. And we want to generalize that to a larger population. Usually, the data that we get from the sample it's a bit of an indicator, but does not exactly match what it is for the entire population. So what we do is, what we can say is usually that it will fall within a particular range, but we can't say it will be exactly this. So confidence intervals lets us do that, and the amount of confidence that we want to express changes how big that range is. So if you want to be more confident, you have to do, the range is a little bit larger, as we can see in the normal distribution curve. So if you want to be 99% confident, then we usually, the range goes from +3 standard deviations from the mean to -3 standard deviations. If we are okay with being 95% confident, then we go to +2 standard deviations and -2 standard deviations, so we can give them a narrower range, but we're less confident with our statement. Statistical significance testing kind of does the same thing, but in this case, what they do is they compare two groups, and in some cases more than two groups, and what they try to determine is whether the difference between the two groups is because of chance or not. Again, usually we have something called the p-value, which again corresponds to our normal curve. So, and we usually pick one value, and it's usually 5% or 0.05, and if it's less than that, then we say yes, we're confident that the difference is really because of our intervention. Otherwise, we're not confident. And again, that 5% comes from that 95% value should fall within a particular range, and if it doesn't, then we know it's systematic or because of a special cause. The z-test and the t-test are what we use when we have two groups to compare, and the chi-square or the ANOVA is what we use when we want to compare more than two groups. And, more than two groups, an example could be where you have a placebo group where you don't really give them an intervention, or a control group. Then you have a group that gets one kind of intervention, and then you have a third group that gets a different second kind of intervention, and you want to compare all three groups to see the effectiveness of both those interventions. So that could be a way to do that. Regression is another way that we can determine the impact of one variable on the other. And essentially, when we're doing regression, we start off with, and this is an example of a scatter plot, which is essentially those dots, and there are two variables in this case. It's the amount of hand rub used, alcohol hand rub used, and the outcome that we're looking at is the number of infections per month. And we kind of plot that data over there, and we kind of see that we can run a line through that data, which kind of indicates the more alcohol hand rub we use, the less infections there are, which kind of indicates a relationship. And in regression, what we're trying to do is we're trying to fit this line so that the error, which is really this, which is how far away each data point is from that line, is minimum. So we're trying to minimize that and fit a line. And what fitting a line does for us is it creates a mathematical equation that essentially lets us first establish that there is a relationship between the two, and what kind of relationship. In this case, it's an inverse relationship. We want more hand rub use, which will hopefully decrease infections. And it also lets us determine the strength of the relationship, how strong that changes. So how much do we want to tweak hand rub use to have a certain amount of impact on the number of infections. And it gives us a mathematical way. In addition to that, it gives us a mathematical way to predict what it would be at a certain level. It may not be as relevant in this particular case, but we can do that. So those were some of the basic methods that we thought would be important to go through. Another important part for quality improvement effort is monitoring. So we want to monitor our outcomes on an extended basis over some time to ensure that our improvement effort is having an impact, and once our improvement intervention is done, to sustain that particular effort in the community. And there are many different tools that we can use to do that. Control charts or shoe charts are a great way to look at a process and stability of that process and to see that we are doing, or we're continuing to improve. Line charts are a great way to gauge that improvement and see if there's any drop in improvement or if you're continuing to make that improvement. Key performance indicators are a great way to keep track of whether we're meeting the goals that we've set for ourselves. Finally, dashboards are essentially a combination of all of the charts that we talked about in key performance indicators in this one nice place where you can essentially go in, look at the different measures that tell you whether your improvement effort is continuing to move in the direction that you want it to. Usually it's updated on a regular basis, so you have the most updated and recently available information. And the way it's designed usually is that you can quickly tell what's going on with all of your disparate measures. And with that, I'm going to move it over back to Rob.
Thanks, Rahul. So I'll now discuss some of the things that Rahul had mentioned and how it can apply to the community level example for a quality improvement project. So let's say you're a member of a QI department or team and you're looking for a focus area for a QI project. And one of the most obvious things or obvious questions you're going to ask yourself is, what are we going to work on, or what gap do we need to close? Right? I mean, that seems like a pretty introductory step within a QI project, but it can be more complex than you think, because oftentimes gaps in quality don't identify themselves or stick out with a sore thumb. Furthermore, when looking for a focus area, it would be ideal to select those that have the greatest amount of impact. So identifying patient populations either by demographics such as age, race, sex, etc., and diagnoses that both have abnormally high readmission rates and make up a significant amount of your patient load or intake will typically have the greatest amount of impact on your overall quality. And that kind of goes right to the next point, which is identifying QI efforts that impact multiple patient populations or diagnoses when possible. For instance, if you're able to build a QI project that can close gaps in care for both diagnosis-specific and patient demographics, you're going to have a greater overall impact. And finally, selecting a focus that is practical and is highly feasible for success is also extremely important. Again, time is always of importance to you, and you need to be realistic in your not only your project focus areas, but your project goals as well. Focus areas that are reasonably feasible can lead to successful intervention, which not only leads to improved patient outcomes, but also helps you and your internal QI team achieve success, which can lead to, can strengthen team bonding and can be motivating for you and your team for future projects. So piloting a project with a small group of patients or within a small department or organization may give you an idea of how effective that project is before you broaden the scope to larger areas. So this is just an example of a data table, and it just shows this particular one is a readmission rate table by patients admitted for particular diagnoses on this slide. And readmissions and readmission rates are just one example of metrics and data outcomes that you can use, but I thought that using readmissions would be most applicable for today because that's common in our work with community coalitions. So if I was part of a QI team, whether that be within a community coalition group or at an individual facility, how would I use this table to identify a focus area for the next QI project? Well, again, when we want to select a variable, in this case it's based on diagnoses, we want to select one that makes up not only a significant proportion of the patient population, but is also underperforming by readmission rates, in this case, based upon a baseline rate. So we wanted to identify diagnoses that has an abnormally high readmission rate in this particular column when compared to the baseline state rate, which is this column on the far right. And looking by just number of discharges, this is the total number of discharges missed. This is the proportion of the discharge total. Looking at just by discharges only, you might notice that behavioral health makes up for patients with a behavioral health diagnosis make up for 67% of the total patient population. So you may think that would be an ideal place to start. But when you look at the readmission rates for these patients, it's at 16.7%, which is actually outperforming the baseline state rate. So these patients these outcomes for these patients are quite exceptional, and you may not be able to move the needle on that because that might have reached the threshold. And looking at some of the remission rates, you see end-stage renal disease with a 35.1% remission rate, and sepsis. Both of these particular diagnoses have significantly higher remission rates than the baseline rate, but they also don't make up that much of the total patient population. So again, your overall impact may not be as high. So in my opinion, if I were given this table and I was part of the QI team, I would probably focus on diabetes patients and heart failure patients, because not only are their readmission rates much higher than the baseline, but they also make up for a more significant proportion of the total patient population. So you're going to really affect the overall readmission rates by selecting these focus areas. So we at the LSQN are fortunate to work with a number of facilities, organizations, and community coalitions throughout our three-state region, and we thought that providing an example of how a community used data for a QI project would be helpful. So using data from a community data report of their Medicare fee-for-service patients, a large Wisconsin community identified a number of potential focus areas for their community QI project. And one particular group of patients stuck out, and that was their diabetic patient population. These patients were being readmitted at an abnormally high rate, especially when compared to the baseline, and also made up a significant proportion of their patient population. Furthermore, there was strong buy-in from their coalition members, as many of the hospitals, skilled nursing facilities, and community agencies that were members of this coalition would definitely benefit from a QI project that improved outcomes for their diabetic patients. So data's role in identifying gaps or needs, or really the diagnostic step within this process, was completed by this group as they used data to identify diabetes as a focus area. They also identified what part of the process needed to be fixed, and that was through the development of the Diabetes Instruction Empowerment Tool, or DIET for short. So they created their own tool by customizing an existing patient-facing tool to be distributed to diabetic patients at discharge and take it with them through the next stages in the care continuum. Finally, for these diabetic patients that received this tool, they determined which information needed to be captured so that they could track the outcomes of these patients. So when a patient received this tool, it was documented, the date was documented, as well as a patient identifier, which was their Medicare number. And then finally, the data source was Medicare claims data, and two outcome measures were determined: patient admissions and admissions. So all these decisions and steps were taken by this group to ensure that they would be able to document and track the effectiveness of the DIET project by using the available data, and we will discuss that in the next slide. And this is really where understanding the importance of leveraging data really comes into effect. You develop and deploy a QI project, but the metrics will be essential to determine and analyze the project's effectiveness. So this group did so through patient-level outcome data, and as I mentioned, those were both hospital admissions and readmissions. So since they were able to document which diabetic patients received the tool by collecting the Medicare numbers, we at the LSQIN were able to include those patients in data analysis data analysis through our access to our Medicare claims data. The data was relatively simple. The data methodology, I should say, was relatively simple. We took the sample of patients that received the tool and analyzed admissions and readmissions per patient for two different time periods: 6 months before they received the tool and 6 months after they received the tool. So this simple methodology allows the group to quantifiably understand how effective the DIE tool was at reducing inpatient stays, and progress of the project was monitored over time through repeated analysis. So the first outcome result from the DIE project was pre and post patient admissions for those that received the tool. Really, these are simple averages of admissions per patient over a fixed time period. Essentially, they're seen as a rate, which again, as Rahul mentioned, works well for comparison, as seen in this graph. So the results of the DIE project were effective in reducing admissions, as admissions per patient dropped from 1.73 in the 6 months before the patient received the tool to 1.27 in the 6 months after receiving the tool. And just like patient admissions, readmissions also saw a decrease for those that received the tool, even at a more substantial rate than patient admissions. So for both patient outcome measures, admissions and readmissions, we did run a test for statistical significance, and were able to determine that the results of the analysis were not due to chance. So going back to the earlier graphs that Rahul shared, the model for improvement pie chart, this is really part of the intervention phase. You're analyzing the results, making changes if needed, and monitoring the progress of your improvement. And you're repeating these steps over and over to ensure that the project is sustainable and effective. So the DIE example is just one of the many community-driven QI projects that we've been lucky enough to be a part of. And we thought that it fits today's theme rather nicely. And just some final takeaways or reminders when using data to drive QI efforts, and most of these fall within the models for improvement that were discussed earlier in the slides today. The first is to use any and all data that is available. Rahul did a great job of discussing the different types of data, qualitative and quantitative, and they can all serve a purpose in both identifying gaps and monitoring the effectiveness of your projects. Select focus areas for QI that has a high impact and are of high importance. This is more of an obvious takeaway, but you really want to get most bang for your buck when putting your time and resources into QI. This next one is a really important one, and we can't stress it enough. Documenting and tracking your data points, while this can be one of the more tedious aspects of QI projects, it is also, in my opinion, one of the more essential. Documenting the needed information can provide both a historical perspective of the project timeline, as well as the obvious need to obtain certain information for data analysis. Next, your data and methodology does not have to be complex, as the development of simple measures can be all you need to determine QI effectiveness. You can get more creative if you wish, but remember, in our community example that we shared today, they had a very simple methodology that was very effective and really all they needed for the project purposes. Use data to test your progress and continue repeating analysis when you have new data to affirm that the project maintains its effectiveness and is sustainable. And finally, don't be afraid of failure and be patient. Improving patient outcomes and meeting organizational or community goals through healthcare QI projects takes time, can be often a complex process. If you follow the model for improvement and are monitoring your progress and documenting your steps, identifying weak spots within your project will be much easier, and you can always make the necessary changes. So with that, and we just have a couple minutes, we would like to open it up for any questions or comments that you may have. Rahul and my contact information is available on the slide. So if there's anything that comes up after this presentation, please feel free to reach out to us. We'd be more than happy to to provide any information and answers that we can.
Thank you. If you do have a question on the phone line, press star then 1 on your touch-tone phone. Standing by for questions. We do have a question from Janelle. Please go ahead.
Yes, let's say that I want to run a data analysis QI project. How large of a patient sample size would I need to have to produce reliable results?
This is Rahul. That's a great question, Janelle. It really depends upon the kind of study you're doing or kind of intervention you're doing. If it's more qualitative in nature, where you're trying to understand the process or exploring what it looks like, you can go with a smaller sample size. You usually don't have the resources and the time to get a sample size of a very large number because you have to get interviews or a focus group. So anything less than 10 or up to 10 would work for that. If it's more quantitative, you want at least 30 or more, unless it's a pilot study. And again, if you're doing, on a small basis and you just want to see whether it's effective or not, and whether you want to continue doing it or not, you can go with a smaller sample size. But the rule of 30 or more usually applies in quantitative data. And the reason we want to do that is we want enough data for that normal curve to look like that bell-shaped. And usually if you have 30 more data points, it will conform to that.
Thank you, Rahul, and thank you, Janelle, for your question. And since we only have about 1 minute left, I think we're going to have to cut things short because I do have just a couple more things to mention. So that really concludes the main portion of our presentation. Once again, please feel free to reach out to either Rahul or myself if you have any questions or would like any more information. We also really encourage you to complete the evaluation for today's event, especially for those attendees wishing to receive continuing education credits. The feedback from the evaluation that we gain, we use to improve upon the quality and content of these webinar offerings. And so once you close this window to the webinar presentation, you will be automatically directed to the survey gizmo for that continuing education evaluation. So we would really appreciate if you fill that out. Also, the recording for this webinar will be available on the Lake Superior Quinn YouTube page at www.youtube.com/user/LSQIN in just a few weeks. So with that, we will conclude today's event. Thank you for your time and have a great day.
Thank you, ladies and gentlemen. That concludes today's call. Thank you for participating.